special live stream of the Scoliosis Research Society Social Media Committee. We are absolutely thrilled to be here, and we're grateful that many of you are joining us and following us across our platform. The SRS, as you all may know, is the leading global organization that promotes education, training, and research in spinal deformity surgery and scoliosis surgery. For more information, you can find the website to be very helpful, srs.org, srs.org. That's the place to go to find a lot of information that actually we will be covering today as well. My name is Ali Baj. I'm a spinal neurosurgeon in Phoenix, Arizona with the University of Arizona. And I am excited to have with me today Drs. Ryan Fitzgerald and Dr. Teresa Pezionis. Dr. Fitzgerald is a pediatric orthopedic surgeon at Children's Orthopedic and Scoliosis Surgery, and he is associated with Johns Hopkins All Children's Hospital in St. Petersburg, Florida. And Dr. Pezionis is a spine surgeon specializing in deformity and oncology at Temple, Philadelphia, also affiliated with Fox Chase Cancer Center. Drs. Pezionis and Fitzgerald, welcome.
Thanks for having us.
Thank you, Dr. Baj. Good to see you.
So now it's just us, which is interesting. So I'm not sure where Dr. Baj went, but from my understanding, when the restream app happens, we're going to get questions from the audience that are going to appear here. So until Dr. Baj gets relogged on. So Ryan, tell me about, there's some differences between adult and pediatric practice. So obviously we both trained in orthopedics. So what do you miss most about adult practice, and what do you appreciate most about pediatric practice?
I think that, yeah, as you mentioned, there are kind of differences there. And so in the adult population, a lot of times you get specific nerve elements that are due to degeneration or early arthritis. And so you can do a very small, minimally invasive surgery and make huge impact. I kind of miss that side of the adult world, being able to get rid of those nerve symptoms. It's a little bit different in the pediatric population. Typically, it's not specific nerve symptoms we're dealing with. Typically, it's more due to changes in the shape of the spine that we most commonly see. So in adolescent idiopathic scoliosis. And so typically that's the group that I'm seeing. And I think what I really like about that is these are big conditions that definitely can truly affect people's lifelong course. And, you know, from being able to treat them non-operatively and prevent them from having to have a big surgery, or if they should be unfortunate enough that their curves get large enough that we do have to do surgery, we can make changes in their lives that last them for the rest of their lives. And we know, especially the most common type of surgery that we have excellent 30-year outcome data on this type of surgery that shows that people do very well. They get married at the same rate, have kids at the same rate, have pain scores similarly to their peers. And that part's really gratifying, that, you know, we can kind of get them back on course with everybody else that isn't dealing with those issues. What about for you?
Well, for me, I mean, I miss all of that about pediatrics. And I can say that when I was rotating through, I always loved how you could do the scoliosis correction on kids, or sometimes later the tethering on kids, and you would just see them grow into healthy, normal, well-adjusted people. And I think that's wonderful. The tissues are also something that I miss. Kids are just so plastic. I mean, you can just do anything to them, and they will run with it. They'll do great. They'll be jumping up and down the hallways, which is something that you don't always get in the adult population. But in the cancer population that I work with, I think it's wonderful to be able to take a patient who is just severely disabled by this disease and not only see them kind of, you know, flourish in terms of their oncologic outcomes, but also see them kind of defy expectations. And I think with a lot of the biologics that we have and the newer chemotherapeutic agents that we have, we are really seeing a paradigm shift with cancer care, where it's not just palliation, it's really more focused on how can you get that patient back function. And that's where a lot of the deformity principles and the oncologic principles are important. I remember a case of a fellow that we saw at Sloan Kettering where somebody came in fused in kyphosis. And we're looking at it and we're saying, like, okay, how can we do better so that we don't, you know, subject patients to this? And that's really where, you know, Mark Bilski and Hanjo Kim and those guys would really, you know, emphasis deformity correction within reason on our patients who came in with a de novo kyphotic deformity. And it's nice to see value and quality of life along with our cancer care and how that's evolved.
Absolutely. And I see we have Dr. Bosch back.
Is he frozen or is he just listening and absorbing? I don't know. Ellie, are you there?
Maybe.
Both of those things. So
we can keep going until we start seeing some of these questions pop up. I've seen him maybe unfreeze. Are you there, Dr. Bosch?
Oh,
not so much.
He's kind of in and out. So have you brought anything? So I've recently, in the last couple of years, incorporated robotics into my practice and trained freehand. I think many of us did. And really, it's become more of an emphasis with enabling technology, robotics, some of the predictive analytics that we're seeing with the unit data, for example. What are your thoughts on that in the pediatric space?
Yeah, I mean, I think that there is, that is really the future of our space, is especially with the analytics, like you kind of mentioned, where I think it's going to help us bring everyone to the same kind of point from a surgical perspective, ensuring that we're really achieving that balance, both in the coronal, but more importantly in the sagittal plane. I think that that's really where it can kind of bring everyone to that same level, which I think is hugely important. As far as robotics are concerned, I think robotics are really helpful whenever minimally invasive surgery is being done. And really in the deformity space where we're trying to untwist these curves that have gotten to a large place, I don't see it being as helpful because typically they are bigger open surgeries. That being said, still, I think navigation is a slightly different thing than robotics. Robotics, for everybody watching, that's kind of a robotic arm that helps you put the drill and the screw in the right spot. Whereas navigation kind of confirms that your knowledge of where screws are going and those sorts of things are exactly in the right place, and that you're getting the biggest, best screw that can help us do a better job of what we're trying to do in the OR. And that technology is something that I use in my day-to-day practice. I started just like you, just putting screws in with my knowledge of anatomy and how bone feels, and I did that for about 5 years. But I think that this just kind of ups that game and takes that baseline knowledge and ensures that you're doing the best, safest thing for people. So it's a really exciting time to from a surgical perspective to be doing what we're doing. And I think that ultimately it's helping patient care, which I think is key and first and foremost, and something that really SRS has been a leader in helping us to kind of help us push these things forward.
Great. No, I totally agree. I mean, I think I have a slightly different take on robotics. And for me, it's really part of the planning software that I think is important, right? Because obviously we would plan, we all used SurgiMap or, whatever kind of program you used as a resident and fellow. But at this point, there's a couple of things. For some of those rotatory curves that you see that there's huge axial deviation, you're right next to the lung, you're right next to the aorta. We're pretty sure about where our screws are when there's conventional anatomy, right? And but when you have dysplastic pedicles where you have something where you almost need to blow the pedicle, you're also using a ton of radiation for yourself and for the patient to really do some of those things safely. Your anatomical knowledge is pretty well on point, and if you've planned the case appropriately, it's fine. But it's still something that if you can do something in a way that's more predictable and safer and oftentimes faster with less blood loss, it's a tool that you can use, I think, to augment the patient care that you're providing. The second thing is I also plan osteotomies on the hardware, on software rather. I plan how I'm going to be doing my correction. So for me, it's more of a tool to make sure that I'm getting as predictable an outcome as I can, and that I'm planning it appropriately, throughout the surgical process. And that's pre-op, intra-op, as well as post-op. So that's more my take on it. So I think useful.
Yeah.
And then also the data that we're generating. From everything that we're entering both into the robot and also into the, for me, it's, unit platform, whatever other predictive analytic platform you use. I think that's something that's also going to be very useful in terms of determining outcomes in our field sort of in the next couple of years.
Yeah, absolutely. I think the field is certainly progressing quickly. And I think the key thing is that you're going to someone who is comfortable using the technology that's best in their hand.
Correct.
And so there's all sorts of versions of that. But I agree, making sure that the surgery we're doing is safe, efficient, and done in a way that's really helping our patients the best we can. And it looks like Dr. Baj has a better connection now.
Yeah.
Your cell phone, or what was the problem?
It'd be great if the moderator is present, right?
You're so clear.
And I hope that you still got the proper introductions here, Dr. Fitzgerald, Dr. Cazianis. Thank you for this. Yes, I am on a better connection. Thank you. I heard a lot of what you all said about the the surgeries and making sure it's safe and effective, and I think that's really important. What I was trying to ask before I got kicked out is before surgery. So let's talk about first kids, right? So parents, mom and dad say our child or our teenagers diagnosed with scoliosis. Let's talk about what the options before surgery are, and really the main one that comes to mind is physical therapy and bracing. So, Dr. Fitzgerald, a lot of questions kind of come up on this topic is, when's physical therapy effective? When is bracing effective? Or when is it just time to go ahead and say, it's time for surgery? So we'll start with our pediatric and adolescent population, and then I'll ask those same questions to Dr. Cazianis.
Yeah, no, those are great questions and things we certainly talk about with our patients every day. I mean, obviously, there's a lot of detail we can get into from a surgical perspective, but everyone's goal is not to have surgery, mine included, for my patients. And so, as far as physical therapy is concerned, it is a mainstay of treatment for people that are having back pain. As far as the evidence in regard to adolescent idiopathic scoliosis, the most common type of scoliosis that we see, the evidence is a little bit more limited. There are certain therapy methods out there, like Barcelona-trained Schroth therapy, that there is some limited evidence that it can be helpful, especially for people that are trained in that method, for smaller curves that are very flexible. Now, I tell families all the time, there's just as much evidence that shows that type of therapy doesn't make a huge difference. But with that evidence being present, if a family is very motivated and wanting to do everything they can, it's something I'm still very supportive of, even though the evidence is here and there. And so our job is to teach you the science so you can make the best decision for your family and your child. And certainly that is a part of a treatment algorithm for a lot of people. Now, as far as bracing is concerned, this is something where we actually have excellent evidence. And so a typical algorithm for bracing for people is when curves are progressive, above 25 degrees, that still have quite a bit of growth remaining. That is a patient population that is ideal for bracing. And what we know is that bracing truly can prevent surgeries from happening. So there was a good prospective study that was done out of Iowa that showed us that they actually had to stop the study early because it was unfair for the patients that didn't get the brace not to get it. And what they showed is that the number needed to treat was 3. And so what that means is if you take everyone that would have to have surgery and you give them a brace and they wear a brace well, that we can stop a third of surgeries from happening. And so I think that evidence is really what we hang our hat on and why bracing is such a cornerstone in what we do. Typically, that type of brace is a full-time brace. And so the second point we got out of that study is the number of hours per day that you wear that brace is very important. So if you don't wear the brace at least 13 hours a day, you may as well not be wearing it at all. But every hour on average that you're wearing it more than that, up to 18 hours, we can get further benefit. So for me in my clinic, for patients that still have growth remaining, that have a curve above 25 degrees, the mainstay of treatment is a brace that is, again, worn with a goal of 18 to 20 hours a day. Great. And then ultimately, if those curves progress, that's when we start talking about surgery. Curves that are above 45 to 50 degrees, where you're starting to lose balance, those are the ones that tend to be kind of worse actors long term, and that's when we start talking about surgical options.
Great. No, thank you, Dr. Fitzgerald. I think that's very helpful, and it's important for families and parents to realize that there are options and good options before surgery is entertained. And I always tell, my patients and families, always get 1 or 2 opinions about this kind of information. These are critical decisions, and you want to make sure you're talking to surgeons, to be honest with you, like yourself and others, who are part of the SRS, who are well informed of the current updates and current guidelines as well as the literature. That is very, very important. And we'll come back a little bit to that as far as some of the novel surgical treatments. Dr. Pazionis, let's put this to the adult side. So you have a 60, 70-year-old female with, she comes to you for scoliosis. And sometimes those same questions are asked. Is physical therapy, a good idea? Will it help? Do I need to wear a brace? Can I do any of these before surgery? How do you answer that? How do you address those non-surgical options with elderly patients who have scoliosis?
Right. I think that's a great question because the indications for scoliosis surgery in the elderly are different than in kids, and the curve magnitude doesn't need to be as large, but also it's not purely based on the curve magnitude. So I ask patients, how bothered are you by your curve? And I look at a very similar, actually having been first oncology trained, there's something called the NOMS framework, where basically you look at neurologic, oncologic, mechanical, and systemic. So for me, it's curve magnitude. Okay, how bothered is the patient by the curve? And then the systemic factors are something that I think are oftentimes overlooked in our population. So just because you can do a surgery, should you do a surgery? So medical history, can the patient tolerate the surgery? Is there going to be something prohibitive in terms of, and this is getting to the next question people asked about blood loss in kids versus adults. Can I perform the surgery safely in the patient and give them TXA and blood preservation strategies? Is that patient going to be able to tolerate an anesthetic? Have the bone mineral density profile been optimized? So if a patient with severe osteoporosis and they haven't been given appropriate medications beforehand, that would not be an optimal candidate for big deformity correction. So essentially, it's really the patient's systemic factors, how functional they are, and how bothered they are by their curve. So whether it be because they have neurologic compression, is it because they're tilted over to one side, they can't stand up straight? Have they developed failure over top of a previous construct? So it's more verging on the quality of life of that patient, and also explaining to that patient that the natural history of an ADIS curve, so an adult idiopathic scoliosis, meaning someone who has had scoliosis as a teenager and then progressed, versus a de novo degenerative curve, are also going to be quite different in terms of how bad that's going to get and how symptomatic the patient is going to get. I think with adults, it's also a discussion about when to do surgery. So usually, unless there's an intervention that needs to happen, like a cardiac stent or some bone mineral optimization, the patient is really never going to be as healthy as they are today, right? So if you have a 60-year-old, it almost behooves you to do a a more complete correction. It's not going to necessitate a revision now versus waiting until they're 75 or 80, and then they may not be able to tolerate that surgery and they're miserable. So I think the bottom line is a lot of things go into it, but it's never really a cut and dry answer, nor is it in pediatrics. But I always miss the pediatric part where you're just like, we're progressing to 50. Nice.
But I want to follow up on that, Dr. Pazionis. Do you have a cutoff, again, elderly patients who sometimes think they're no longer candidates for surgery? Do you have a cutoff for that? Is there any certain age where you cannot offer surgery?
So I think that this is something that we all used to have a cutoff, but now with some of the telomere research and the longevity research that we're seeing coming out of SRS, it's becoming less of a factor. So for example, I had an 86-year-old come to my office yesterday. I'm reviewing her scans and I'm like, ooh, 86. No, and I walk in and I'm like, is your mom in the bathroom? No, and it was the patient. She looked about 60. So I'm like, God bless her, she looks great. But I think we have to recognize that not every 86 is 86, right? So I think it really depends on the patient and looking at their frailty indicators. We used to have psoas cross-section at L3 for sarcopenia, but as some of this telomere testing, I think, becomes more mainstream as it becomes available through commercial insurances, that may be more of a reason to approve or deny someone, surgical option for that systemic factor.
Yeah, no, that's a great point. I think it is important for folks to realize that there are a lot of options nowadays with technology, innovative techniques, less invasive techniques.
Yeah.
Really, we should not be not necessarily declining, but we really should be offering good intervention and effective intervention to patients at any age because they want to live longer and healthier and be more active.
Yeah.
And it can really help with that.
And I care how the patient looks. And I think we all care about this. How does the patient look? Not necessarily how does the x-ray look. I mean, I like that all my x-rays, and I put it up at a meeting and everyone's happy, right? But practically, I would, and this is sort of the Neil Anand school of thought, that you would sometimes rather get a little bit less of a correction and have the patient be perfectly functional and happy versus sometimes if the patient can't tolerate a huge surgery, right? So I've started doing a lot of, the prone lateral and like the circumferential MIS technique for selected patients where I'm thinking, all right, like Jehovah's Witnesses, for example. I can't give you a huge osteotomy. You're going to die on the table, right? It can't give you blood. So if I need to do something where there's going to be virtually no blood loss and maybe accept slightly less of a correction, that's something that's an option.
Perfect. Yeah. No,
Yeah,
I think that's a
I
great.
think
Oh, sorry, Dr. Fitzgerald. Actually, I'm going to bring this back to you if you want to follow up on that. But also, if you don't mind, if you can address for some families whose children or adolescents are having scoliosis surgery, what does life after scoliosis surgery look like? Can they participate in sports and play, soccer and gym and track and all of that? And what are the things that you just tell them you're never going to be able to do? Because I think it's important for families to understand that kids and adolescents who have scoliosis surgery can really live full, meaningful life and really continue to do a lot of the physical activities and sports that they like. Can you talk about that and what parents need to know about life after scoliosis surgery for their kids?
Yeah, absolutely. And I think one key point is that, as you can tell with all these topics, it's very complex. There's a lot more to this where it's not truly just one answer. So I think it's really important that if people have specific questions regarding their spine treatment, that you need to contact your physician. And although the SRS doesn't recommend or refer specific positions, you can go to srs.org/find, and you can find members that should be knowledgeable to help guide you through these decisions. But kind of back to your question, let's say we're talking about a fusion surgery. Our goal is to get you back to doing everything. And so everyone's postoperative protocols, depending on what was actually done in surgery, does vary a bit. But kind of a baseline for me is there's two phases of surgery. The first phase is the soft tissue healing, the skin healing, the muscles healing underneath. And so typically we consider all that soft tissue to be fully healed and stout by the 6-week mark. And so at that 6-week mark, that's why I allow people to start to jog, swim laps, soak in bathtubs, be in the pool, those sorts of things. The second phase of surgery is the bone underneath healing, because the primary goal of that surgery is fusion, turning those bones into one long bone. And so once that is fully turned into one long bone, you can go back to doing everything you want. So for me, 6 months after surgery, that is a pretty stout fusion. And so for me, at the 6-month mark, I allow my patients to go back to all activities, except for contact football with pads and contact rugby. That one with repetitive trauma to the area, I typically have people wait until a year after surgery. But those patients are able to do absolutely everything they want. I have gymnasts that, if we reacted quickly enough and are able to save the majority of their lumbar spine from a motion perspective, that are back to doing all of their activities, doing their backflips. I have patients that have had fusions that are triathletes, have run Ironman, have done all of those things. So while it is a big process and it is a recovery time, our goal is to essentially get you back to doing all the things that you were doing before we did something surgical.
Thank you. Thanks for that. And Dr. Pazianos, back to you. So on the adult side, what do you tell patients to expect after these big scoliosis surgeries? How quickly can they recover? How quickly can they go back to normal activity? Especially driving. I think driving is obviously very important. It comes up a lot. When do you tell patients they can go back to driving, traveling, resuming normal activities after scoliosis surgery for adults?
So again, everybody's different. And I just remembering a patient I had in clinic yesterday who has a list of activities that he very rightfully wants to do. And I think that driving, number one, I have to be off narcotics, obviously. Just if it's impaired driving, if you're on either narcotics or medical marijuana, depending on whatever state you're in, at the time where you're driving a vehicle. Otherwise, if you have any problems with your right foot, that needs to completely resolve for at least 6 weeks prior to. And if there is a residual foot drop or something that the patient has come in with, you actually have to retest with driving with the left foot, and you actually have to go through the DMV again. Generally, I'll tell patients, I'm like, listen, I'm not going to pull your license, but you can't get in a vehicle, If I have any inkling that a patient is going to do something unsafe, then that is, sort of where we're mandated reporters, and we actually do need to do that. So I just ask people not to get in the vehicle. I've never had a problem with that. Usually people are resuming driving by about 2 to 3 weeks post-operatively. That's around the time, of course, where they're off the narcotics. And they are in a back brace. So I tell people, listen, if it's your child is sick or your spouse is sick and you need to get in a car and drive to the hospital, sure, go do that. But you probably don't need to go to Costco 4 or 5 times. My parents love it. Costco every day. Okay, so maybe take a break on that. For long distance driving, generally, anytime over 6 weeks, while using appropriate ergonomics with the steering wheel is appropriate. I have a similar protocol, I think, that Brian has to whether or not patients can get back to activities, right? So maintaining precautions, no bending, lifting, twisting for 6 weeks. I do give patients a back brace more so for wear outside, not really because it does much on top of the construct, but it does allow them to heal, and it does act as a reminder not to do those things. Patients do require it. I know a lot of folks will say, okay, like never again to horseback riding or whatever else. Generally for anything where there's going to be motorcycle riding or repetitive vibration, horseback riding, any mountain biking, anything like that, usually 6 months minimum. And then for any contact sports, really to make sure the fusion mass is maintained up to a year. I do a CT scan in most, if not all adults at this point routinely at the year if there's any question about whether or not they've fused, but it's really becoming more of a routine thing that we do in the adult population. I think the other thing that's important is I will tell patients, listen, I'm not going to keep you in a bubble after that 6-month mark. If your friend who's in the room with you, anyone does something ridiculous and falls off a bike or gets hit by a car, we're all going to get injured, okay? That's not because of your fusion. That's because something happened to you and you got injured. Because you have a fusion, it's going to be a little bit more complicated to fix whatever goes on with you, but it's, hopefully still fixable. But just, exert caution in your life. Like I have one guy who really wants to jump out of planes and he's about skydiving. I'm just like, listen, I wouldn't, but like if you must, please wait a year. Please wait until you're fused, right?
That makes a lot of sense. That's important. Those questions are important, right? I mean, that's what families want to know.
Yeah.
They can resume normal activity, drive, etc. We have a few minutes left here, and I'd like to conclude this by asking each of you a question about what excites you most about the future of scoliosis and deformity, and what do you want to tell families and patients to expect down the road? What do the next 5 to 10 years look like in terms of innovations, new techniques, new research that's going to help them and hopefully make surgery or non-surgical treatments better in the future? So Dr. Fitzgerald, I'll start with you. What are you excited about in the next 5 to 10 years when it comes to pediatric and adolescent scoliosis?
Yeah, it's a great question. And I mean, I think there's a lot that's exciting in this space. Obviously we have this gold standard surgery of fusion, but there's a lot of other newer techniques that are coming to light that we're gaining more data on that seems to be good options. So vertebral body tethering is something, it's a non-fusion option that can be helpful in modulating growth and slowing curves down to the point where you don't have to have a fusion. There's other techniques out, like a posterior dynamic distraction device. That's another non-fusion option that's newer out there that has potential as well. I think outside of the surgical realm, though, too, we're also making strides in the basic science where, previously we had something out there called the Scoliosis score that wasn't the best. We were hopeful we'd be able to better tell progression of scoliosis based off of that. That one didn't pan out, but there are newer techniques out that are still in early phases that if we can get that kind of honed in, it won't be this blanket approach of if you have a curve of 25 degrees, you get a brace. If you get your curve gets to 45 degrees and starts to get off balance or above 50 degrees and you need to have surgery based off of these genetic things, we may be able to better predict all of those outcomes so we can have it be a more specific treatment for each individual. So I think that those things are all kind of revolutionary and very exciting, not only working in this space every day, but more specifically for our patients. And I'm excited to see those things come out.
Great. Thank you for that. And Dr. Jonas, in the last minute or so on the adult side, what's to be expected in the next, say, 5 to 10 years that's going to make our patients with degenerative deformity, scoliosis, hopefully better?
So I think the most exciting thing is looking at some of the predictive analytics data and doing better with how we're correcting curves and predicting which patients will do better with which surgery. And that allows us to both do less surgery on certain patients who may not be able to tolerate it, as well as advising those patients appropriately who need a larger deformity correction to prevent failure in the future. So I think that the fact that we are accumulating a lot of data on patient outcomes and on broad fracture, on revision rates, and actually looking at the biology of the patients and the radiomics and correlating those two things, I think is going to be very important in the future. And I'm excited for that.
Great, wonderful. Well, thanks to both of you very, very much. I apologize for the technical glitches in the beginning. Great topic. I know we'll have a follow-up on this in the near future. We can spend the whole day talking about it. For those online who want to get more information on some of the current research and topics that are related to this, again, go to the website, srs.org, and certainly there you have access to a lot of literature, guidelines, and specialists that live in your area, in your home state or country, that could help you and your families. So thanks very much, Dr. Tazionis and Fitzgerald, for doing this live stream on behalf of the SRS Social Media Committee. And hopefully we'll do this again in the future.
Absolutely.
Thank you, Dr. Bosch.
Take care, everyone.